Hello, everyone. Nice to be with you again. Thanks for a wonderful discussion last time. In fact, I think we did discuss quite a few topics from today's syllabus also, so you might be able to get free early today. But let's see, we have an interesting case also. And let me just start with the presentation. All right. So today we continue from the basics of communication to specific things like communicating bad news or serious illness communication, it is also called, and the prevalent models, the formal, accepted ways which have worked well for people, and the need for communicating bad news, how to do it, and dealing with collusion, like we a little bit touched on it last time too. And then another topic will be about angry situations. There were a few questions also last time, how to deal with people in angry situations. So what is an ideal method? Actually, it is an unanswered question. It has to be individualized. There are multiple factors, cultural aspects, as I was talking about, Western society commonly more individualistic, more taking calls on their own, and in Eastern and our setup, more commonly interdependence, joint families, a lot of people are involved. Talk about death is sometimes a taboo, as we talked last time, but things are changing, and research has shown that people want to know. There are joint finances. So we had a good discussion last time. Someone pointed out that maybe somebody else is spending the money, so everything can't be left to the patient, and we may have to interact with the family, which is pretty fine. Yeah, we don't want to cut out the family. We just have to have the right balance between the patient's right and the family apprehensions. I said this last time, the slide is the same, that one thing we need to remember is that if the patients have the right to know, they also have the right to not know. So we can't be running after them, trying to give them the bad news if they don't want to know. So it depends upon the patient. Multiple ways are done, models are there. Full disclosure as is these days being more talked about. Partial disclosure or non-disclosure, in case the patient doesn't want to know, then you have to work around with the other people or the legal heirs of the patient. Why do we need to tell them? I mean, there was a time when nobody used to tell, and there's a lot more people who don't want their loved ones to be told. So as we said, that there is these days a lot of finances, and many people are well off, and they've earned hard their life and worked hard, and they want to close their life's businesses. People are shifting to quality of life. They may want to spend some money on themselves before they go. They have earned it and not leave everything behind or do something with their will. So you can see how important it is for a person to know that they have a limited time left, or the change in their activities of daily life. So it may not be only death, it could be disability, which is oncoming, like in our neurological disorders, motor neuron disease and all that. And this avoids hospital hopping, doctor shopping. We have seen so many times that people don't tell about it. Then the patients keep going to another hospital, and just don't want to either accept it or disclose it. And there can be barriers between the patient family. We said everything cannot be hunky-dory in all families, and there may be sometimes a little bit of not in the best interest of the patient. People may want to hide some stuff. So what do we do? So as we said, we need to make an individualized model. So if the indication is, of course, the patient wants to know, we don't have to spend time on this. And another, as I said last time, this kind of conversation happens before actually we also know and there is a serious atmosphere in the room, that if there's something serious in your test, would you still want to know? This is like, in a way, a warning shot. In a way, you are being honest with the patient that I don't know the report, but let me know if you want to know. So if they said yes, then you still give them a chance to make a bit of a serious business kind of atmosphere. Sometimes patient that time say that, no, actually, I know better you tell it to my daughter or wife or husband or son. So give them another chance. And if they still confirm the desire to know, we adopt a narrative approach. And this is what is loosely, or sometimes in toto, followed in many places where serious illness has to be communicated. Basically started from MD Anderson Cancer Center, and it has been well accepted across modalities to use the spikes model, as we call it. It's basically an acronym for the 6 parts of the S is for setting up, uh, the same as the basic communication, but with a little bit of more sensitivity. So we're going to talk a lot of serious stuff. So uninterrupted, not distracted, mobiles off, sitting position close by, not across a big table. So make it as comfortable as possible. Maybe have a glass of water along there, and no disturbance. Then there is a patient perception, how ready for news patient is. This is important. You can't just go blindly every time to every patient. If the patient knows nothing, it may be a little more tactful approach. May have to be, you may have to go slow, maybe break it into 2 parts, call them another hour or day. And if the patient already knows a lot, and including prognosis, we can go on to more meaningful business with them. So it is important to ask them that, what do you think about your illness, and what is your idea of all the reports and all, and you've been doing consultations. The third is I is for invitation, as we already talked, to disclose when, how much, to whom. This is what we ask the patient. And according to their wishes, we go accordingly. Either we tell them or tell somebody else nominated by them. The third is the most important, of course, giving them the knowledge. So this is 1K, but all the basics we talked about, teaching back slowly, chunk and check, give and check. Are they understanding? Or give a break at the right time. Maybe give them chance to vent their emotions. So, and then in a very non-technical way, or in simple language which they understand. And sometimes if it is not the same language, common language, we can use interpreters of the language which they understand, and give it slowly. And of course, empathy is very important, and we have to, be with them, identify with their emotion, and support them through it. And the last part is strategy. So once this is over, is plan for the future. It can wait, because many times by the end of the knowledge, patient is not in a condition clear-headed to talk about exact management of drugs or surgeries or chemotherapies. So we can always, unless it's an emergency procedure to be done the same day or the next day, we can even ask for, if it's a chronic disease, they can come back and with their own questions and answers, and then we can go ahead with the strategy. As last time, I'd request that if you have any thing common, please keep chat away in the chat box, and we'll discuss it as and when we stop. So, or raise your hand. It's all okay. We can do it informally. And then stay with the patient for a little bit if you have time. Don't just walk away after telling the bad news. This is quite important, in fact, that you just throw it at them and go away. If possible, some member of the team, whether it is a medical, nursing, or whoever resident, can stay for a couple of minutes, 5 minutes with them, and then, till they get used to it. And either we give them more information. Sometimes we have handouts in our own specialties where we would want them to read and come back with more questions in their mind. And patients may have a lot of things. First thing is that, is it curable? What are the treatment options? Am I going to live? how long, all these questions may be there, or patients' relatives may be there, depending on what the scenario is. The important thing is not to get swayed by their emotions, and although be empathetic, we have to be very, very objective ourselves, and we have to give honest and clear answers and precise answers. Or if we don't know the answer, we clearly say that at this point of time, I don't know. This is the broad thing. I'll have to get back to you after more reports or after a few weeks, how we see the treatment is working. Very, very important to be candid with them at this point. This is a video I made, along with my residents. It's a simulated thing, not a real patient, and not the greatest of videos. This is probably a few years back when I got into communication. This was the first video we made, and that was nice to be act as the patient. So this is somebody who thinks that they have just a normal neuropathy, and ultimate, but they have a motor neuron disease, as many of you may know. It's a very, very, relentlessly progressive illness, and can lead to extreme morbidity and even death also. So just trying to show what are the basic points we may want to follow in a brief 3-minute video.
कैसे हो? I'm good, sir. In fact, कैसे हो? I'm good.
Is the sound coming?
Yes, sir.
Okay. All right. Sometimes it doesn't.
Sir, in fact, कैसे हो? I'm good, sir. In fact, the last medication you gave me worked wonders for me. My twitching has improved by 80%, and regarding my muscle weakness, I'm feeling improvement in that too. Yeah, I have your reports here. उसके बारे में बात करेंगे. तुम्हें क्या लगता है अपनी बीमारी के बारे में, क्या फीलिंग हो रही है? कुछ आइडिया है? No, what I think last time we had discussed about that. You told it's some weakness in the nerves. So, in fact, after taking the medication, I feel it was just because of after my fever. So, I guess I'll be back to my full power in another week or so. Okay, we actually will go into the reports. Do you have somebody with you want to call in, or you want me to explain everything to you, including the diagnosis, the prognosis, and what is going to be the future of this illness? No, I have come alone. You can tell me what's the matter. I'm saying so because unfortunately I don't have very good news based on these reports. It's true that it's a nerve disease, as we discussed last time. But after doing the electrophysiological test, we have come to a diagnosis which we call as motor neuron disease.
You can see I'm using a lot of technical language, which is not desirable. We all learn.
And sometimes they degenerate. The problem is that this disease is not a short-term disease. It's a long-term disease and usually progresses over the coming days and months and years. You must be mistaken here, because I just have a very mild symptoms of bit weakness, a bit twitching. That guy, I guess, was wheelchair bound, and I think there must be a mistake here. We can repeat your test anytime. It's not a big test, but from the reports we have now and our electrophysiology team we have discussed, we are not much in doubt that it could be anything else apart from motor neuron disease. You don't have to be, everybody with motor neuron disease does not become wheelchair bound immediately. That was the latest stage of disease which we see in Stephen Hawking and all. But in early type, like you are likely to be physically active for quite a long time. Yeah, that's what you need to understand, Doc. I have just been married. It's been just a month. Okay, and all this while, on all these 30 years, I have just been looking forward for earning and taking care of my family. It's my time to enjoy my life, and I don't think so I'm ready for this thing right now. I know, I can understand that. I wish I could tell you things were better than this, but we could sit and discuss what are the possibilities. It may not be a cure, but which can support you to move and be ambulatory or keep moving and keep working for a longer period of time. We don't have to do it now. We could you could come back and we could think about what all the medications we could be using.
Yeah, definitely. I think it's too much for me to take right now. I think I'll take some time to.
So yeah, so this was just to enlist. As I said already, you may have noticed that there were a few flaws regarding the language and technical language, but just to give an idea that we can make it a little more gentle for people, and I'm sure I would like to have your comments on this too, and when we do the discussion. Now, coming back to this, we had discussed in the last time's case, which is collusion is a conspiracy of silence. We talked a lot about this, but I'll go through just for a revision's sake the slides. So basically, we all need to know that apart from rare cases of malafide intent, mostly the family is trying to protect their loved ones. Sadly, this is from us that we may not give them bad news or uncomfortable time, but obviously they need our help as well. So they are dependent upon us. They are also in a vulnerable position. If you go into history, before about a few decades back, it was thought to be inhumane to disclose bad news to the patient. But as for the reasons which I already said, things are changing, and people are not only talking about death and longevity, they're talking about quality of life and bucket lists and what they want to do before they die. And there is palliative care, as you are right now going through this sessions of palliative care, and you're going to be the teachers of the same. So good palliative care is available not only to let the patient go gently, but also make their life more bearable. So all these things have changed the way we look at chronic and terminal illness in today's times. So and as physicians, it's understood that it's difficult to give bad news. As I mentioned last time, we are all trained to save lives and be heroes, and losing a patient or not being able to cure them is taken as a failure. We also have to get out of that mindset to do our best and then also support them when we are not able to cure our people. And there is a charter, I said, it's on the government website, where actually some of these things are mentioned that we need to inform. Not informing the patient may also be, land us into a bit of a trouble. Sorry, I got that chat going. So the thing is not to challenge the belief of these people, these family. If we confront them, they need us, we need them too, for the patient's sake. If we antagonize people or challenge their belief, in a rude manner, they will not. And so we can't force things to them. But what we can do is that, we can calm their anxiety, talk to them about it, ask the reasons that why is it they want to hide it from their loved ones, and we might be able to get them on our side. If this doesn't help, we can also give them the data. As I was talking about some papers and research, you can see this is done from India in tertiary cancer center, and you see 94% of people wanted to know whether the illness is cancer. 85% wanted to know the week by week progress and their chances of cure or not. So you can see, I mean, if we look from the family side, things may be different, but if you take survey of the patients, most of them actually want to know what is going on with them. So we have to assess the situation and go accordingly. Okay, before we go into this, I'd like to open the chat. Sometimes Prakhar says, sometimes a patient after hearing bad news requests for a second opinion. What to do in these cases where we know that nothing much can be done anywhere? For example, in a massive intracranial hemorrhage. Well, that's a very good question. And not only in the situation of bad news, but generally otherwise also. And for one person, if you ask me personally, um, I strongly believe in second opinions. Of course, not doctor shopping is not what we want them to do and run around spending their money unnecessarily. But in cases, we have to have insight. If there is something which may be done somewhere else, we should be the ones actually telling them that, okay, you can take, I have a colleague, I can refer you to them, they do the same thing. I do that very regularly, that see, your epilepsy is not being cured here. I am trying my best and this is all what I have in mind, but maybe I'm missing something. Why don't you go nearby Delhi? And I have a colleague who does the same epileptology practice there, and I can even write you a referral or fix up your appointment. So second opinions are important. Leaving our ego aside as doctors, we should always encourage our people to take second opinions and never inhibit them. But this situation, of course, what you're saying is different, that there is not much you can do. So in this situation, I would tell them the fact that, and sometimes you have to tell them that I know what I'm doing. I have seen a lot of, you have to tell them your expertise in the thing, that I think I can handle it very well. And what as I was saying in the video, that we can do your tests again, but as far as I've seen and along with our team, we really don't have doubt that it is motor neuron disease. So even after that, if they want a second opinion, I would support them in whatever way possible, not risking the patient's life, of course, that shifting on a ventilator or something. They can take the records, we can give them the reports, the summary. Is that what you wanted to know, Prakar, or is there anything else was there in your mind? You can unmute yourself and talk. We have time.
Yes, sir.
Sorry, I think we can't hear you very well.
Dr. Praga, maybe you can try without your headset. Maybe that will do. Or if there
Yes,
is.
sir. Bad opinion to ICU the patient ventilator and they take their.
I'm sorry, I really missed that half of what you said. Ventilator, what?
Yeah, so these patients are sick and they want to shift the patient to other hospital. As soon as they hear that the patients are sick and they are very, they might not survive the event. So it's a very common occurrence in our ICUs we face.
Yes,
So
yes.
often when we tell the bad news and they want to shift them to other hospitals.
Absolutely. It's a normal reaction that you are saying, like you have already given up and telling us patient not going to survive. Maybe we can try. If the patient is anyway going to go, let's shift somewhere else. So as I said, my answer remains the same, that we tell them everything honestly, clearly, give them the option, tell them the risks of shifting. And if they want, obviously we have to go with their wishes. If they are bent on this thing, but we must tell them honestly that I don't think there'll be anything different, but it is your patient and you can shift. These are the risks of shifting. We can provide an ambulance with or without a ventilator, depending upon how the patient is, facilities are available. So once we are honest and clear with them, then they have to take the final call. There's another one, Roshan Patil, with the second opinion, but sometimes patients stop everything and choose the treatments other than allopathy in cancer settings, which anyway won't help them at this stage, especially after disclosing the poor guarded prognosis. Absolutely, we all face it every day. We let me just stop sharing and then we can go this much time. We only have one more module so that we can talk face to face. Like, yeah, okay. Where is the chat? Yeah. So uh, they might stop. So this is what is being talked about as patient's preference. So we all know. I mean, there was a similar video which I had last time didn't show. Was that as soon as I said, as soon as a patient goes contrary to our opinion, We many times just back off and say, you can do whatever you want. I told you, you didn't take it. Now you're going to die. Now you wasted your time, you wasted your money, you wasted my time. We need to understand that, nobody wants to die. It is out of their desperation, or maybe lack in our communication properly, that they could not understand what we were trying to tell them, and they tried. Or it's a matter of belief. They have belief in other than allopathy, whichever form of medicine it is, and there is a limitation what we can do. I mean, what I usually tell and what I usually try to do is not get upset, not get angry, repeat to them what I already told them, that this is not, in my knowledge, in the form of medicine you're using, I'm not aware of anything. I'm not expert in these forms of medicine, but I don't think the best chance is with your chemotherapy. So we have to tell them, and if they are not, I just don't ask them to just go away and go to another doctor. The benefit of that is, if we are all working towards the patient may be misguided or guided by somebody and beliefs or people around them. And once they try that, I have so many people coming back. They don't like taking lifelong anti-epileptic drug. They stop there was some clinic somewhere in the hills, you must have all heard about. I don't want to name names here. And they used to, they used to take advantage of people, that will cure your epilepsy and all that would be done. And they used to go away, stop their medications. And they used to say, when I asked what we are taking from that clinic. So now they said, okay, then go. That is not the correct thing. Go away, never come back to me. Then the communication is broken. So many of them did come back, because they realized that in their hope of getting well without taking lifelong medications, there may be something. So all I can say is, just keep ourselves open. After our best guidance, if they are not following the advice, just tell them that this is what I think is best for you. But if you do plan to come back and start chemo, we are there for you. Just this line might give them the confidence of not, just not having the courage to come back. Dr. Suranjan, as an oncologist, I often have to face such scenarios, that patient with an early stage cancer, after knowing the diagnosis, has a denial and do not believe at all, and ultimately fall in the hands of so-called alternative medicine, again come back when there is nothing. Yeah, sad. I feel bad when they have lost time, especially in a disease like cancer. If they've lost time and you had told them, and the best way to do this is treat your patients like your children. And many of us have children. I think most of us, and many of them have grown-up children, adolescents, and you know how children can be rebellious. They may do stuff which is not good for them, right? And we never turn them away. Like we say, the prodigal son or prodigal child, you come back and we always take them in. So if we follow that with our patients and they come back, we'll feel sad, rather than saying, look, I told you so. I told you, you didn't listen to me. We can just say, we can restart again. I mean, this is the ideal thing. Sometimes I know we all are humans. We will get upset. And all I'm saying is, don't show it to them. We can be upset. We can feel bad, but may not show it to them. How to make patient understand? How can we convince? I think, talked, but I'm willing to talk more about this after the few more slides which are left. Keep putting your stuff in the chat box. I'm going to reshare my presentation. Oops. So this is the second thing which a lot of us are concerned about, is which has led to violence against doctors and hospitals, and there's the angry situations. Well, it can happen to us also. We can lose our cool, but what we're talking about more is when the patient or their attendant lose the cool. And anger is a very high energy consuming negative emotion. It leads to stress, or can come from their stress of the frustration against the general situation they find themselves in, their life falling apart. It may not be directed, or it can be directed at something which they felt was not done in their favor or correctly. But the thing to understand is if not managed properly, it can turn to rage. Rage is when what we feel is our thinking capacity is bypassed and we go back to our primitive brain and we, fight, fright, that kind of a reaction, and we can get violent. So that can be really, deleterious and counterproductive. So we need to stop anger till it turns to rage. So all this breaking of furniture and beating up the medical staff is in the state of rage. So if we can try our best not to get in this, so we have to act in time. So we have to facilitate in letting the anger. The first intention we or idea we get that somebody is really angry and we need to listen to them. Listening is very, very important. We did talk about it last time, and we stand and listen, and of course with a respectful and not in a defiant position. Confident eye contact I talked about, not looking away or not looking into their staring into the eyes directly, somewhere midway, and maintain distance. It is important to look at our safety. And we should have help standby once we are expecting such a situation in the security staff. But maintaining a hands-off distance is like if somebody lunges at you, you are safe and not get hit. After that, once that is heard, then make them sit down. Sometimes they may not want to sit when they're in total rage and anger. After that, we sit down and discuss if there are any common things which they feel we feel they're saying it right, and they get our point of view that actually it was not the hospital's fault. This is how it happened. So this is only done once they have calmed down, and we try to find a way out to do best for the patient rather than keep blaming each other. So main crux is that we don't have to get charged. We are humans. We are stressed in our work, busy emergency, especially at junior level resident, they can suddenly, flip and, get back at the patients. As far as possible, we should be avoiding that because the patient is one who's in the major issue. So I talked about 4 C's of communication. When coming to angry situation, I add 2 more C's. The communication, as we said, should have been complete, clear, concise, candid. In an angry situation, it's important to remain calm. We should respond and not react. Basically, we should not bypass our thinking capacity and find commonality. There must be some common ground somewhere. We agree that, see, we don't want to things to happen, but there be that there are limited facilities in the patient. Every patient may not get every facility and every machine which is required all the time. There is a system which we have to follow. So all these things need to be done to diffuse the angry situation. So that is all in the slides, but we can continue the discussion where we left. So I'll stop sharing. And for people who wrote about the movie list, I have got the mail, but it's been very busy at work. I will get back to you about the movies depicting such situations. All right. Where do we go back to? Dr. Indira Yadav, I joined late. Did you want to know anything? You can put your query if you joined late and you missed something which you feel should be discussed. We can discuss again now after the case, whenever. Parul says how to draw a line by getting ourselves not getting affected from patient sad emotions and yet be empathetic while breaking bad news. Yeah, it is a challenge for all of us, but now you're all reasonably senior. You have noticed, I'm sure, that it does come with experience. It does come with experience. It's a lot of these are coping phenomena, and becoming a bit neutral to getting affected, or what is it, or what the psychiatrist called something like transferent counter transference, that our mind does learn, because otherwise we would have a nervous breakdown 2 years into our profession. So automatically, I don't think we made special efforts, but we know that there's a point beyond which if we can't help, we don't. It happens. It has happened with me many times over, when you did your best and something happened to the patient without anybody's control or fault, and the patient had a bad outcome, and you really get affected. There are people who are known to you, people who you got attached to over years, and you will get affected. So I can't say we can be 100% immune to such things. The more caring we are, the more we get involved. So that is why there has to be a balance between, as you said, between being very emotional, or too much sympathy, to empathy. So empathy, which we learn over time, and to know that I can understand what you're going through, but I can't completely know. We don't like to tell patient that actually I am also. We don't say I went through this. People start saying I went through this. You lost somebody, I lost my some relative. Best thing is not to join issues and be for them, that I can understand what you're going through, and I can feel it must be really bad, although I can't really feel what you're feeling. So it basically validates their feeling, doesn't make them feel small, doesn't make them feel weak, that they are doing something wrong by crying in front of you or something. So that is what it is. So we need to, we do learn. I think most of us do learn. In fact, the issue these days is towards the other side, that when we are becoming a bit too unattached with the humanity, not as doctors, even otherwise in life, and that is a bit counterproductive. That affects our empathy. Okay. Kalindi Singh, it is especially difficult to prognosticate parents of small children without getting involved. True. I mean, these are all true. You just have to be as much as possible. I mean, as I'm saying, that if we have to validate people's feelings, we need to learn that we have to validate our own feelings. Sometimes you might just become teary-eyed in front of those parents. It's okay. You have kids and we have kids, and it's okay to become. We can't be too hard on ourselves, always be on a citadel. Otherwise, we'll burn out. One of the sessions we do in our big communication course when we do is doctor burnout, medical staff burnout. And being in this profession is not easy, and we do burn out. So let's not have too many expectations. What I'm talking about is ideal scenario. We will falter. We will not do things ideally. We will break down. We will all have, only thing is that try to maintain a balance as much as possible. It may not be always possible. I totally agree with you. Anger is moment. If we let it pass, it may help. But what is the best way to let the anger moment pass? Yeah, Dr. Narendra, the best way, I mean, there are many best ways. You can have your own improvisation. What I was talking about general is that just listen out. So the best way to let anger flow in another person is listen out. Don't try to cut into what they're saying. Don't try to counter. If that they are wrong and you are not responsible for what that happened. I'm not saying you have to accept, oh, yes, we did wrong. No, just keep quiet and listen to them and tell them that we'll do best we can. In fact, to the extent, sometimes we ask that there should be a register lying there, and we tell people that if you want, you can write this complaint, and there is an independent person in the hospital who goes through it. And if we are confident that it is, misunderstanding, let them write, let them feel good. Many of them, they won't even write because their anger is subsiding by the time we offer them so much of acceptance. One more difficult communication is when the patient is a relative known to another doctor or colleague. The communication may become medical class between the two doctors and the patient is left out. Or the doctor might request not to inform the patient as he might not be able to make it. Yeah, here the doctor is acting like a relative, what we were talking about. But the more example which I use during communication course to our teams is, this happens more often in our rounds. What we call is, we start talking over the patients. Have you realized many times the patient is lying down? One, we have this, somehow many of our places, I don't know, all over India, in a place that when we start talking in English, the patient won't understand. Many times this happens. We start talking the prognosis and worse things when the patient is lying there, and we change our language to English. Many people know English, they'll understand. Even if they don't know, they are being left out. So then we change our practice. As we said that, talking over the patient can give to unnecessary doubts. If at all I have to talk to my residents, I tell the patient first, that these are trainees. They have to learn. Everything we are talking about disease here in front of you is not about you. And even then, now we've started doing the discussions away from the patient. We talk relevant in front of the patient and not just bypass the patient. What we need to talk to the patient, talk. Otherwise, we go to the next room and have a teaching round there. It's very important to have patients' involvement and their, respect them, not as a body lying there, but as a person lying there. As a pathologist, we face patients having malignant histopathology report, want to know their status, how to break the bad news. Should we refer to the treating doctor? Hari. Well, I haven't thought about that. This situation never came. Let me just give it a thought that usually the report comes to our clinics and the other ones, but I'm sure in a situation where the pathologist is directly in touch with the patient. That is one reason actually, we keep telling our basic sciences people also that they should have this basic course in communication also. But I'm sure it's not only that they have to go through the course, but they know. So if you're stuck in this situation, what would I do? If I was a pathologist and I hand over the report and the patient or the attendant wants to know, I think the best course, what I would go through is, since I don't know everything about the patient's clinical status, it is not the histopathology, it is the general status of the patient. Patient may be walking around or patient may be on a ventilator, So I would not find it right for me to start giving prognostication. But if the situation is there, I don't want to be dishonest also and tell them the report doesn't look good. The same way, and you say that, okay, you want to know who are you? You are the patient or something, whatever. You can say it doesn't look good, or there is suspicion of a malignancy here, and the rest, of course, over what is going to happen, what treatment is possible, you need to talk to your treating doctor. So without being, fending them off unnecessarily, we limit to what is our brief and give them that limited information. Maybe that is what, is that all right to you? Okay. Sripriya, do you want to go to the case?
Sure, sir, with your permission.
There more queries, comments in the meantime, and if there are more, we can take them up after the case. Sripriya? Okay.
Dr. Kalindi?
Good evening, sir, and good evening to all the participants. Am I audible?
Yes, ma'am.
Am I audible?
Yes, ma'am.
Yes, you are audible very much.
Okay. Thank you very much, sir, for your insights on this difficult topic. I am Dr. Kalindi Singh. I am working as assistant professor at Sri Lal Bahadur Shastri Government Medical College, Nechok. My case is about a 69-year-old gentleman. He was diagnosed as carcinoma prostate with bony metastasis. Initially, he was evaluated for generalized weakness, body aches, weight loss, and decreased hemoglobin. He was empirically started on anti-tubercular treatment, but did not have any benefit. Also, he had some urinary complaints for which he was evaluated. A PSA was done, and it was found to be elevated. Next. So he was evaluated for urinary complaints, and after workup, he was diagnosed as carcinoma prostate. He underwent high inguinal orchidectomy for the same. He had improvement in urinary symptoms, but his complaint of generalized body aches and weakness persisted. Relatives were advised that he needed a prostatic biopsy for exact characterization and grading. However, they were not willing for any further investigations, and they wished to proceed with the treatment based on the available investigations. Also, they requested us repeatedly not to reveal the patient his diagnosis. They feared that the patient would not be able to bear the shock of the diagnosis and undergo any kind of treatment. Also, they wished that the patient should have minimum investigations. So at presentation, these were the surgery findings. He had an ECOG of 2, pickle negative. On per rectal examination, he had an enlarged hard fixed prostate. There was no skeletal tenderness. At last follow-up, he was doing well. He did not allow a per rectal examination, but otherwise his GC was well and he had no complaints. His treatment and significant investigations. His initial PSA, which was done last year, was more than 2000. His CT abdomen pelvis showed a grade 5 prostate enlargement with bilateral vesico-uteric junction obstruction and bilateral hydroureteronephrosis. The biopsy was done from a deposit in the scrotum, which was suspicious of metastatic deposit. Bone scan showed extensive osteoblastic skeletal metastasis. He underwent high inguinal orchidectomy in September last year, and after the orchidectomy, his PSA had dropped to more than 1000, and his serum testosterone was 19.05. That means he had achieved castration. He was subsequently started on injection docetaxel, which is palliative chemotherapy. He received 10 cycles and he had a significant improvement in his symptoms. His appetite improved, his weakness was improved. And we decided to stop after 10 cycles because he had resolution of his disease-related symptoms and had started developing numbness of hands and feet and joint stiffness due to the chemotherapy. His last PSA was 43 nanogram per ml. The psychosocial aspects. The patient lives in a joint family with his wife, 2 sons, daughter-in-laws, and their children. He is a retired JBT teacher and he receives pension. He is unaware of the diagnosis and he thinks that he's brought to the hospital for multivitamin and calcium injections. Otherwise, he is content with the treatment and he has no complaints. The relatives, they seem to take good care of him. They have not revealed the diagnosis to him as they feel he will not be able to cope up if told about the diagnosis and he may not undergo the treatment. Presently, he is on tablet bicalutamide, 50 mg once daily. So the main concerns here are if patient is aware of the diagnosis and stage of the disease, he may choose a different treatment plan. Also, patient may have some personal wishes which he may want to be fulfilled. If despite the relative's request, we inform the patient and patient develops symptoms of depression and refuses treatment or does something untoward, how will we counsel the family? And also patient's relatives may not bring the patient to us again if we express our concern of express our intention of informing the patient, and the patient may not receive any treatment at all. The summary, a patient diagnosed case of metastatic CA prostate, post-palliative chemotherapy, presently on hormonal treatment, and patient is unaware of his diagnosis since 1 year. Now the discussion points, how the diagnosis should be revealed to the patient, how to convince the family that patient should be aware of the diagnosis, and if the patient is actually unable to cope up, how to counsel the family.
Yeah. Good discussion. A lot of points to discuss, including collusion and, as I was talking, not following treatment. So since we have in the last 2 sessions talked about them, I would wish if people want to give their comments, you're going to be involved in teaching of these concepts. So it's a, the same thing which we discussed last time in a different manner and a slightly different situation. So would anyone want to either give comments or just unmute yourself and start talking? Dr. Indira, would you want to speak out what you are writing? To start the discussion, maybe?
Yes, sir. I want to say that this is very important to counsel the family first. If they will understand the situation, that is very, very important to tell the patient. So they will, if they will ready and understand the point, they will bring the patient. Then patient counseling is easier, I think so.
Yeah, I think it's a good point, but it may not work in all the situations. If that is the ideal thing, if the family is in this case, I'm sure, Dr. Kalindi, you would have counseled the family to tell it to the patient and all, and not telling led to possibly negative outcomes. The patient didn't know that it was such a serious disease, and
Yes, sir.
patient may have their own views about dealing with this. Maybe the patient want to go more aggressive early on in the disease rather than their family feeling that the patient doesn't want aggressive treatment. This is the complication which happens if we leave everything to the family. So that I mean, we keep saying it's at the cost of repetition, but at least knowing what the patient wants to know or not is important. Then we can go the way the things happen. We don't have to tell it to the patient, but getting their invitation or consent to who's the best person. You might not know, and the patient might say, tell it to my family. But once you've seen the patient, to just talk to them that who should we be talking to. Itna agar hum pooch lein, even then we are on the right track. So that's all additional thing I would want to say. But these are very complex situations, and yeah, someone put out their hand.
Yeah, sir. Very good afternoon, sir.
Yeah, hi.
Actually, if we are discussing about this particular case, then the patient, a retired government personnel. So in our practice, our day-to-day practice, most of such patients usually know about their prognosis, usually know about their diagnosis completely, as they people are coming to the cancer hospital. So they must have read either on the hospital papers or on the hospital signboards that they are coming to the cancer hospital, or they simply ask the nearby patients or someone else, cause family and relatives just can't take care of them uh, all the time. So they must come, they must have had already come with some other person's contact also. So they must be knowing that they are in cancer hospital and they are taking treatment for the cancer. So in that scenario, we simply have to ask the patient directly, बाबा जी आप क्या जानते हो आपकी परेशानी के बारे में, आप क्यों आए हो मेरे पास? So in most of those cases, they themselves open up a little bit. Yeah, I know I have this, and then we can find some way to goes into that and put up the diagnosis in either front of that patient or their relatives.
Yeah, very good point, Dr. Jalad. Very good. I mean, that is the P part in the spikes protocol, and it's an excellent idea that you might all be thinking that people doesn't know, and if you ask them, the whole family is trying to hide, the doctor is trying to hide, and you never ask the patient the simple question. Asking the patient, what do you know about your disease, may clarify everything, and things may be much more smoother after that. So yeah, interacting with the patient is very important. Not telling them directly or it depends upon their wishes, but interacting. Now the second part is if anyone talks about that they may actually get depressed and not able to cope. So does anyone have a view on that? That if they agree, the family agrees, and we tell them it looks like a doctor's apprehension. Is that what you meant, Dr. Kalindi? What did you mean by that? What was in your mind?
Yes. Yes, sir. Sir, I have seen one patient who was told about the diagnosis, and after finding out about the diagnosis, the patient attempted suicide. So it is actually a matter of concern. Sometimes the family is actually right. Their judgment about the patient is right, that patient will not be able to cope up. So
What can happen? I mean, probably it happens. Probably that person already had a psychomorbidity before, and they were more prone. Everybody doesn't, but yes, I mean that is a distinct possibility that people may get so depressed. We do have cases where people do jump out of hospital wards and windows. You all have seen them, heard about them. It happens not so uncommonly. People undergoing chronic illness therapy, committing suicide. So that is to be known, and that is the reason why we don't force our diagnosis. So if the patient wants to know, we tell them, and if there are any signs that patient has a psychiatric comorbidity or needs psychiatric counseling, most of the palliative care units and chronic disease units have psychologists, psychiatrists, and counseling is actually a matter of routine. Once you give a serious illness prognostication. Many of the centers have it, but it may not be universal, and you need to be careful. So it is good in case there is such a history that patient has psychiatric comorbidity or has a tendency towards that, then first get the evaluation done before talking to them. Even if they want to know, just get evaluation before talking to them. So yeah, it's a bit of a dicey situation. I don't know if I have the exact clear answer of every situation, but our aim is to be as clear as possible, respecting patients' wishes. And you may not win every time. That is there. You may not get it right. You might not tell to 10 patients and they may die without taking treatment. That is also, in a way, the patient is dying if the patient knew and the relatives feel that the patient is 80-year-old. He has made many lakh rupees, and now if he starts spending on his chemotherapy, then he will finish off all the money and go, and what will we be left with? He is anyway going to die in a year due to cancer, and he has earned 40 lakhs, and if we're going to spend 25 lakhs and he's going to die, and we are only going to be left with the rest after he dies, then why spend too much money? But that is not ethically right. The person has worked hard on their life, and the patient wants to spend the money on themselves. They should be. So there are immense benefits of people knowing, but of course, I'm totally there with you that so much difference in personality, cultures, that we all have to find our own way to it based on broader guidelines as we talk about, and the rules of the country. Anyone else? Did I miss any query? You want to talk about it? So that is why it is important to have a set guideline in front. Every time you may not write, you may get 8 right, you may be wrong twice a time. But if you are universally validated guidelines and a practice followed, which is accepted in your hospital and unit, then you won't feel too bad about having, not good outcomes all the time. It is not possible to have good outcomes all the time. Yeah, that's true, Dr. Suranjan, that it becomes very, very difficult without the patient knowing. Yeah, we don't have to discuss. Even if you get an idea that the patient knows, then we don't have to force it down their throat. And if and as Dr. Jalaj said, if you ask them and you get an idea that they have some idea that they are having a chronic or a terminal disease, then that is good enough. Then you can talk about the treatment. Every time we don't have to talk about the prognosis. Unless the patient asks that how long do I have to, we don't have to talk to them about the death all the time. So, but at least if they have an idea that they have a chronic disease, then that is good enough for us. And the rest can be done through the family. I agree to that point. Any other point, Dr. Kalindi, you wanted to talk about in your case?
Sir, regarding this patient, I would just like to mention that I also feel that this patient knows his diagnosis, like Dr. Jalaj mentioned, and he probably found out in a very unpleasant way. He was caught smoking by his wife when she told him that you are still smoking, you have cancer, and you are not getting any multivitamin or calcium injections. You are actually getting chemotherapy. This was what his daughter-in-law told me, and after that there was no discussion in the family about it. So all of them know about it, but they are not talking about it to one another.
So it was used as a weapon, in an angry situation. Yeah, it happens sometimes. This is the problem with rage. whether it is in medical communication, doctor, patient, patient, doctor, or in your friends and family. And sometimes you say the worstest of things when you are in rage, and you regret the rest of your life that you shouldn't have said those things. Yeah, it's sad that it happened that way. Maybe it would have come like a bullet to him, but that's how things happen many times. Okay, then you can stop sharing the presentation. We can see if we have any more discussions. Otherwise, we'll hand over to Sri Priya for what she wants to do for the rest of the time.
If anyone is having any other queries related to the same topic or the particular case scenario, we can continue discussion. Otherwise, I think Dr. Parampreet would also enjoy half an hour early break.
Yeah, no, I actually have to be in another meeting in some time, so it will be useful for me to have a break in between. But no, I'm happy to stay another few minutes if someone has to talk about. This is also important topic regarding.
We have started receiving thank you messages, sir, which means that maybe.
I take them. No, I think we've discussed a lot. I'm very happy. It doesn't happen in every time in every group, but I mean, especially maybe you being medical professional and into the teaching yourself. So it's been very, very exciting and fruitful discussion, I guess. And I'm anyway open to be contacted. So if we've done, I would say thanks to you and Sri Priya, and we can end the session for today.
Sure, sir. Thank you, Dr. Parampreet, for joining us for the second time. And as everyone would agree, this was another interactive and informative session for everyone. So thank you everyone for joining us for the evening as well. And with the promise that we will be meeting again tomorrow with another interesting topic and another eminent faculty. This is Sri Priya along with Dr. Parampreet signing off from the Tips Eco Hub. See you tomorrow with another topic. Till then, everyone, take care. Bye-bye.
Bye-bye.